Assalamu alaikum everyone, welcome back once again. So today I have come up with a new interesting case, that is NEC. NEC is an acute gastrointestinal emergency in neonatology. It is one of the important causes of mortality and morbidity in preterm newborns. Actually, it is an acute inflammatory injury of distal small intestine and proximal large bowel. The pathogenesis of NEC is multifactorial. It includes immature immune system of the preterm newborns, altered gut flora, that is dysbiosis, milk substrate, and inflammation and injury of the uh, mucosa. These all factors contribute together for the pathogenesis of NEC. What are the risk factors? Risk factors include prematurity, of course, then umbilical flow abnormalities in Doppler, including reversal or absent and diastolic flow, polycythemic newborns, hypoxia, perfusion-reperfusion injuries, perinatal asphyxia, umbilical catheterization, broad-spectrum antibiotic usage, newborn NH2 blockers, and of course formula feeding. So when to suspect NEC in newborn, especially NEC is seen in preterm in infants, that too less than 32 weeks. 85% cases are seen in them. Term NEC are seen very rarely, only they form the 10% cases. Now staging of NEC. So we have an important staging known as Bell staging to classify NEC. Bell staging is actually not a continuum. Some patient can present with advanced NEC and with minimal signs and symptoms, but to develop a uniformity for managing NEC across the centers, this staging has been very helpful. Stage 1 is actually the suspected NEC, only with minimal signs like systemic signs like apnea, like bradycardia, temperature instability, lethargy, refusal of feed, with some local signs include abdominal distension, increased feed residues, and in some cases this parectal bleeding. And locally we can only have dilated bowel loops and nothing else. So this needs to be managed with keeping patient NPO, starting him on IV fluids and amino acid, that is TPN, and starting on broad spectrum antibiotics as per the microflora of the NICU, prevalent NICU. Usually both aerobic and non-aerobic gram positive negative cover is to be given as Kleb, Shilla pneumoniae, E. coli, Pseudomonas aeruginosa, Staph aureus, and Clostridium. These are some organisms which form the most common biota for causing the NEC. So a good cover should be given. And in case of stage 2, that is actually called the medical NEC or definite NEC. In this stage we have more important local signs like bradycardia, patient has thrombocytopenia, metabolic acidosis systemically, and locally patient has increasing abdominal distension, abdominal wall tenderness, mild abdominal wall tenderness, and on radiological investigations patient has pneumatosis intestinalis in 2B, 2A, and portal vein gas in 2B. So it should, in 2A we have to keep patient NPO for 7 days, starting him on TPN, IV fluids, and prompt antibiotics. In 2B we have to keep the patient NPO for at least 14 days, and antibiotic coverage and proper fluid management should be done. Stage 3 is the surgical NEC. Locally more advancing signs like bowel wall tenderness, erythema, induration, ascites on radiologically. There should be ascites present, and usually there are signs of pneumoperitoneum and peritonitis. So needs prompt surgical management. Usually the mortality in surgical NEC is around 100%, and usually overall mortality is 20 to 40%. So best strategy for managing NEC is early recognition and prompt intervention. How to prevent NEC? Use of antenatal steroids in pregnant women presenting with preterm labor or premature rupture of membrane has significantly shown to decrease the incidence of NEC, as the steroids improve the gut maturity of developing fetus. Avoiding formula feeding, following standardized feeding protocols, usage of probiotics, especially lactobacillus rhamnosus, usage of lactoferrin, restricting the use of empirical antibiotics, broad spectrum antibiotics for a maximal of 5 days period, and avoiding. In this case, you can see a preterm newborn who actually came to us 10 days back at 32 weeks of life in view of prematurity. Was doing well till yesterday at around 9th day of life. He started with lethargy, refusal of feed, increased pre-feed aspirate, bilious usually, with locally abdominal distension, clear this increasing distension with visible bowel loose, as you can see in this video, with absent bowel sounds and parectal bleed. So we investigated this newborn, and we found out that his platelets had fallen. He was having metabolic acidosis along with thrombocytopenia. Also CRP was increased. So we kept the patient NPO, started him on IV fluids and amino acids. Respiratory support was given. Hemodynamic stability was maintained. And the patient was started on broad spectrum antibiotics. We did an X-ray. We found out distended bowel loops with bowel wall edema along with pneumatosis intestinalis, and UAG abdomen was also done. That was showing some free fluid along with pneumatosis intestinalis. Patient was managed as case of definite neck, was kept NPO 7 days. Now patient is all fine.